In order to ask questions, you will see a question and answer box in the Zoom toolbar at the bottom of your screen. If you have a question at any time, please feel free to pop it in there, and we will address all of the questions at the end of each talk. Even those that we don't have time for, we will respond either in the Q&A box or by email if it's more appropriate. So with that, and right on time, I have the pleasure of introducing our very first speaker, Dr. Phil Bach. Dr. Bach is coming to us from Edmonton, where he works with our PCRM Edmonton team. Dr. Phil Bach is a urologist. He did his undergraduate training at McGill University before pursuing his medical degree and specialty training in urology at the University of Alberta. He then completed a fellowship in male reproductive medicine and microsurgery at Weill Cornell Medicine in New York City. And upon finishing his training, Dr. Bach was appointed assistant professor in the Division of Urology at the University of Alberta. His main urological practice is based out of the Diane and Irving Kipps Urology Center at the University of Alberta. So, Dr. Bach, I'm going to invite you to go ahead and share your screen.
Excellent. There we are. So thank you very much for the kind introduction, and thank you very much for giving me the opportunity to chat here today. I wanted to just kind of take some time to quickly go over the management for male infertility. And so we'll take the next 40 minutes or so just to go over kind of the pathway that the patient flows through when they come in for their male fertility management at PCRM. So to start, I wanted to kind of quickly just frame the discussion with the impact of infertility before we delve into the assessment, and then probably go quickly through the management and management options for male infertility. So let's talk about the impact first. It hasn't been too long since there have been a number of pretty alarming news articles in not only the US and Canada, but also throughout Europe and also throughout Asia about declining fertility rates. And it seems to be a topic that is at the forefront of people's minds around the world. And one group that looks at this and in detail is actually the World Bank. And there does seem to be some truth to these concerns. If they look at fertility rates in North America, you can see a fairly precipitous decline over the last couple of generations, to the point where we're now just under replacement, just under that 2 there. And we're seeing similar trends across Europe, across Asia, across South America, and to a lesser degree, but still across Africa as well. If we look at Canada specifically, you can see here that the prevalence of infertility has risen quite steadily over time. Whereas it was only about 5.5% back in 1984, it's come up to about 15 or 16% as of the latest data from 2010. So this is definitely a real problem, and a growing problem, it would appear as well. Now, in terms of causes of infertility, there does appear to be misconception out amongst the public that infertility is primarily a female or a woman's problem. When they looked at causes of infertility in the data, though, you can see here that there's a male factor comprises anywhere from 50 to 60% of infertility cases. And so that's where it does become important to investigate the man as well in couples who are presenting with infertility. So how do we do that? Well, we start off with the definition of infertility, which is, as many people know, the inability to conceive a pregnancy after 12 months of regular unprotected intercourse. So our investigations and our assessment for male infertility is fairly standard. It starts with a history and physical before proceeding into investigations. And on the male infertility side, the history and physical are critical. The common adage is that you should be pretty close to 90% sure the cause of infertility based on history and physical alone. So how do we investigate? Let's start with the history. It's fairly comprehensive. We're looking at a number of domains, and we won't go through each one of these individually, but suffice it to say, we're looking to see if there are any issues sexually that would impair the man's ability to deposit sperm within the vagina or to conceive naturally. Developmentally, we're looking for any childhood and developmental abnormalities that could affect the function of the testes, the main one being cryptorchidism. Medically and surgically, we're looking for any conditions that could affect hormonal function, that could affect sperm production, that could affect ejaculatory function. The family history is important to screen out for potential genetic conditions that especially if male brothers or male relatives have also had issues with fertility. The social history is important because there are a number of lifestyle modifications and lifestyle factors that can contribute to fertility problems, which we'll delve into a little bit further in this talk. On physical exam, it's a fairly general physical exam with a focus, as you can imagine, on the genitourinary system. Obesity is something that can cause significant hormonal abnormalities and has also been shown to affect the health and quality of the sperm. Gynecomastia we're using as an indicator of hormonal imbalance. And in terms of the genitourinary exam, we're focusing on the phallus to make sure there are no abnormalities that would impair the deposition of sperm within the vagina during intercourse. Testicular volume is important as an indicator of testicular function. The epididymis, we're looking for any obstruction or any dilation that could indicate obstruction. The last two things that we're looking for on physical exam are critical, and those are the vas deferens and the varicocele. And they're important because they can only really be detected well on physical exam. So the vas deferens, there's no good imaging for a vas deferens. And so without to identify the presence of vas deferens, you really have to do a physical exam. Varicoceles can be detected on ultrasound, but the only varicoceles that warrant repair are those that are clinically palpable. And so that's why it's important to look for varicocele on physical examination. In terms of investigations, the bedrock for the infertility assessment is the semen analysis. And when we're looking at a semen analysis, we're really looking at three parameters. We're looking at the sperm count or concentration, motility, and morphology. And of these three, I would say count and motility are by far the most important, mainly because if you don't have sperm, you're not going to be able to conceive. And those sperm that are there need to be able to swim in order to get to the egg in order to fertilize. Of these three parameters, I do think morphology is the lesser important, and that's mainly because the new criteria for morphology is fairly strict. And so normal semen analysis has only 4% normal morphological sperm. And so in my view, whether you've got 96% abnormal sperm versus 97 or 98%, it becomes less of an issue so long as you've got good sperm concentration and good sperm motility. If we've got an abnormal semen analysis, or two, ideally, abnormal semen analyses, then we usually proceed to an endocrine evaluation. And the goal here is really to assess the testosterone, which the reason for that is we know that intratesticular testosterone is critical for spermatogenesis. And there's no good way to measure intratesticular testosterone. Most men are not keen on having aspirates directly from the testis being drawn on a frequent basis. And so as a stand-in, we use the serum testosterone, which we usually measure in the morning. And there is some data that would suggest that there's a correlation between the serum testosterone and intratesticular testosterone. And so because it's an easy test to draw, we use it as our surrogate marker for intratesticular testosterone. The other hormones that you see here are really testing the function of the hypothalamus pituitary testicular axis. And so we're trying to determine if the testosterone level is abnormal, is it an issue with testicular function? Is it an issue with pituitary production of hormones? Or if there are other issues that could affect the testosterone production? FSH is critical because it's one of the hormones indicators that the pituitary will send down to the testis to stimulate the Sertoli cells to guide spermatogenesis. And we use it as an indicator of testicular failure. So in men with an elevated FSH and smaller testes, there's a higher chance that their abnormalities, if they have them, are related to testicular dysfunction rather than an obstructive cause. LH is important here as the driver for the Leydig cell in the testis to produce testosterone, whereas estradiol has an important role in terms of negative feedback at the hypothalamus and the pituitary level, which can decrease the stimulation that the testis gets from LH and FSH. And I think for a community physician, in terms of investigations for male infertility, if you've ordered the 2 semen samples and the endocrine panel, you're good. There are a number of other investigations that we will use that I've listed here for completion's sake. But these are not ordered for everybody. These are used in very specific scenarios. And we're happy to order them once we see the patient and initiate their assessment for their fertility. The key thing to note here is that imaging is not mandatory. A lot of individuals will get a scrotal ultrasound as part of their infertility workup for men, but there's not a lot of information that I can't get off of physical exam that I would need to get an ultrasound for. So usually the only time I'm ordering an ultrasound is if I'm feeling something concerning on my physical exam, such as a testis mass that could be suspicious for cancer, or if it's a very difficult physical exam. And so some patients will have a body habitus that doesn't lend itself well to physical exam. And in those situations, then I will get a scrotal ultrasound. But it can sometimes be misleading, especially if there is a varicocele seen on ultrasound that I'm not able to palpate clinically, because though the evidence would suggest that those subclinical varicoceles do not warrant any treatment. So now that we've kind of gone through the assessment of male infertility, the next step is, what do we do with the patient who comes in and who presents with male infertility, and what are the options for management for that patient? In terms of management for male infertility, I kind of look at it as a kind of stepwise progression. And so we always start with lifestyle modifications before proceeding on to pharmacological or medical options, and then finally moving on to surgical options. So let's start with lifestyle modifications. So where does this all stem from? Well, if we look at kind of sperm counts and fertility rates over the last generation, we noted at the beginning that there's been a fairly sizable increase in infertility rates in the last generation. And when we look at what could be the cause of that, the common culprits are the genetic versus lifestyle or environment. Now, seeing such a rapid change over just one generation would kind of make it seem that it's less likely to be genetic, which usually results in accumulated changes over time. And so that's why we focus more so on environment and lifestyle. And the other reason why I like to focus on lifestyle and environment is because they are modifiable. Genetics, there's nothing a patient can do about his genetics, whereas when it comes to lifestyle factors, these are things that are within a patient's control. And I find that it can be very empowering for a patient to know that there are things that he can do to improve his reproductive function. So what do we get into when we talk about lifestyle factors? Well, the first is obesity. And so some of the population level data looking at obesity and fertility has shown that as BMI levels increase, the odds of infertility also increase. And this was done in the United States, and there were about 50,000 men in this study, and they were able to see clear kind of increased odds of infertility as BMI started to increase. Now, this was also reflected when they looked at semen parameters as well. And so in this study here, a retrospective study of 500 or so couples who presented for fertility at a single center, you can see that as the men became more and more obese, they had more and more abnormalities in their semen parameters. And so they had higher incidences of oligospermia or low sperm concentrations. And they also had higher incidences of low progressively motile sperm, so lower motility and concentration as well. So what can we do when we need to address obesity? Well, it always starts with diet and nutrition. And these are kind of the recommendations that I have when I talk to men about dietary changes. I always tell them that, things that they can do to improve their fertility and their reproductive function are very similar to what a cardiologist or a heart doctor would recommend. So we'll tell them to increase their fruit and vegetable consumption, decrease their fat intake, increase their antioxidant intakes, decrease red and processed meat if they're getting animal protein, getting it from fish rather than meat, and decreasing or increasing, if they're getting fatty acids, increasing unsaturated fatty acids. The other side of obesity is, of course, exercise. And there is actually a very good and well done study looking at the specific question of the role for exercise training in improving reproductive function for infertile men. So this was actually a randomized controlled trial that was done, looking at 556 otherwise healthy men of reproductive age with infertility and with partners who had normal infertility workups. And so they were randomized to 24-week supervised moderate intensity aerobic exercise and resistance training that was observed, that was overseen by exercise physiologists, and that were titrated to their VO2 max levels. And so it was a very, very well done study. And what they found was that across multiple different groups of infertility, different types of abnormal semen parameters, there was a significant improvement in not just semen parameters, but in the outcomes that matter. So clinical pregnancy rates and live birth rates. So whenever patients do come in and I am advising exercise, I'm telling them, there is good high-level data that increasing your aerobic and resistance exercise training can improve your fertility. The other side of lifestyle includes recreational drugs. And so this is why we ask about this in the social history. But things like tobacco, alcohol, and recreational drugs, primarily marijuana and cocaine, have been shown to have impacts on fertility. And this has these studies have looked at primarily semen parameters. Tobacco has been shown to be associated with worsening semen parameters in a dose-dependent manner. So the more they're smoking or the longer history of smoking, the more the likelihood of them having abnormal semen parameters and by extension, impaired fertility. With regards to alcohol, the studies have shown that a moderate amount of alcohol is reasonable, but it's when you're getting into excessive alcohol intake that you can have negative impacts on fertility. And the definition of moderate intake is about 6 drinks per week. So I'm usually telling patients to stick to 6 drinks a week or less, and if they can go with less, then that's always better. When it comes to recreational drugs, things like marijuana, cocaine, I usually am advising patients to avoid them completely. Again, we don't have a lot of good cause and effect data when it comes to recreational drugs, but the associations are strong. And when it comes to guys who are hoping to do whatever they can to improve their reproductive function, I always advise that if you're looking to take as much as you can into your own hands, then avoiding recreational drugs will be likely beneficial. So what about medical management? When we go to pharmacologic options, it all kind of depends on that testosterone level, because the goal of any medical management is really to increase intratesticular testosterone levels. And as we were mentioning earlier, we use the serum testosterone level as our surrogate. So if a man's serum testosterone level is low, I'm interpreting that as him having a low intratesticular testosterone as well. And so our goal with any medications is to try to improve or increase his intratesticular production of testosterone. And so the options we have to do this are listed here below. So we've got 3 classes of medications. We've got selective estrogen receptor modulators. The one that I use most commonly is clomiphene. We've got aromatase inhibitors. The one that I use most commonly is anastrozole. And then we've got gonadotropins. And so this can be most commonly, the one that's most commonly used is HCG. It's important to note that the SERMs and the aromatase inhibitors are used in this context in an off-label capacity. The gonadotropins are indicated and are on label for the management of hypogonadotropic hypogonadism. So How do these work? Essentially, clomiphene, it will affect the estrogen receptors at the hypothalamus and at the pituitary. So the patient gets less negative inhibition at the hypothalamus and the pituitary, which causes more LH and FSH to be secreted, which increases the stimulus cells produce testosterone. Aromatase inhibitors, the way that they work is that men have a fair amount of aromatase in the peripheral tissues that convert testosterone to estradiol. And it's also thought that there's a fair amount of that also convert testosterone to estradiol. So in men who have elevated estradiol to testosterone ratios, so if the estrogen or the testosterone to estrogen ratio is over 10, it's under 10, then I will usually use an aromatase inhibitor to decrease the conversion of testosterone to estradiol, and which will result in increased testosterone and also decrease the negative inhibition of the hypothalamus to further drive more gonadotropins. HCG is essentially a biochemical analog of LH, and so if the oral pills, the SERMs and the aromatase inhibitors, are not getting normal testosterone range, then we'll use direct stimulation of the lady with HCG to drive or hopefully drive more intrinsic testosterone. Now, the key thing to remember is that the one class of agents to avoid is exogenous testosterone. So it doesn't matter if it's gel or dermal or injectable. What exogenous testosterone will do is that it will completely negatively inhibit the hypothalamus and pituitary, and it will completely shut down the production of testosterone. It will likely shut down spermatogenesis as well. So the studies that have looked for or that have tried to find male birth control have essentially used exogenous testosterone in patients and have actually had fairly good success in shutting down sperm production. So the key thing to remember here is there is no role for exogenous testosterone in a man who is trying for his fertility. All right. I put a couple of slides here just talking about supplements and antioxidants, mainly because it's something that we do get asked fairly frequently from patients. And there's a lot of, these are over the counter typically, and there's a lot of different supplements and different supplement regimens out there. This table here is from the Cochrane review, and you can see here that there is a small but clinically significant improvement in live birth and clinical pregnancy rates when with antioxidants compared to placebo. However, the quality of the evidence is quite low, and there is a lot of heterogeneity in this evidence as well. So when patients ask me about supplements, I will tell them, I'll be fairly honest with them, and I'll say that, there is evidence there to support their use, but I'm also very, very leery of recommending them myself. And the reason for that is these supplements are fairly poorly regulated in North America. And so it's a bit of a buyer beware in terms of what you're actually getting. So this study looked at the top 17 over-the-counter male fertility supplements. They looked at their list of 90 of active ingredients and found that only 17% of them of the listed ingredients had a beneficial impact on male fertility. And so when they created a score of the composite efficacy of these supplements, it was quite poor. And this is what we see not just in the US, but also in Europe as well. So this is an Italian study that looked at 21 different over-the-counter male fertility supplements. And when they compared the ingredient lists to the literature, looking at not just the ingredients themselves, but the needed amount of ingredient to have a positive effect on male fertility, they found that only 2 of the 21 agents would have likely resulted in higher expected or improvement in male fertility. The remainder, the gross majority, would have resulted in lower efficacy or no efficacy at all. So my advice to patients who come with questions about supplements is, if you get all the nutrients you need from a healthy diet, that's always the better way to go, rather than relying on supplements that are typically not very well vetted by the authorities. So let's move on to surgical management in terms of, once we go past the lifestyle and the medications. The only other option I have for optimization is if the patient has a clinically palpable varicocele, we can repair the varicocele. This video here is showing how I do it. This is only one way of doing it. This is a microsurgical varicocele repair, where we go in through the inguinal region, we dissect down to find the spermatic cord, which has the arteries and the veins. We carefully dissect out the veins under microscopy, and we divide them and tie them off, and so that they are no longer engorged. And the literature would suggest that 70% of men will see improvement in their semen parameters with varicocele repair. But the key thing is that it has to be a clinically palpable varicocele. Subclinical varicoceles are those that are just detected on ultrasound and not palpable clinically. There's no evidence that fixing those will result in improved semen parameters or fertility. Now, other options for varicocele repair, I think that the majority of centers across Canada probably have their radiologists angioembolize varicoceles, which is a very reasonable option as well if you don't have a urologist who does microsurgical repair where you are working. So once we've kind of completed all the optimization of the fertility with either lifestyle factors, by optimizing their hormone panels and fixing varicoceles if needed, then I usually send the patients back to the reproductive endocrinologist, because if there's sperm in the ejaculate at that point in time, then I recommend using the sperm for whatever method of assisted reproduction is best fitting. And so here it all kind of depends on the total motile sperm count. If the patient is fortunate enough to have over 5 million motile sperm, then IUI is an option. Otherwise, if he has between 500,000 and 5 million sperm, then IVF is recommended. And if there's fewer than that, then ICSI is the recommendation. So my job, I find, is really to make sure that all the parameters in terms of hormones and varicoceles and lifestyle are optimized. And then we work with our reproductive endocrinology colleagues to hopefully help the patient conceive using whatever sperm is present in the ejaculate at that time. The key thing to note here is after all the optimization interventions are done, we usually give the patient about 3 months before we recheck a semen analysis and to determine what the best method of conception would be. And the reason for this is the sperm production cycle is usually around 70 to 90 days. And so I usually want them to have a fresh cycle, fresh sperm cycle with all their parameters optimized to give them the best chance of improvement in their ejaculated semen parameters before moving on to assisted reproduction. Now, that's kind of how we would approach the patient who has sperm, or if we're able to recover sperm in their ejaculate. What about the patient who doesn't have sperm? And so this is the patient who is got what's called azospermia, which is defined as the complete absence of sperm on 2 semen analyses. And this is probably the most severe form of male infertility that we encounter. And it affects about 11 or 15% of infertile men. Now, when we look at azospermia, we usually break it up into non-obstructive versus obstructive. And so when I'm explaining this to a patient, I'm trying to figure out, is their lack of sperm a result of an abnormality in sperm production, which is equivalent to non-obstructive azospermia, or are they producing sperm normally, but it's just the sperm are not making their way out to the ejaculate, which would be obstructive azospermia. And in terms of which one is more common, about 60% of men will have non-obstructive azospermia compared to 40% who will have azospermia or obstructive azospermia. When it comes to trying to differentiate between the two, we're relying on physical exam and really on that FSH. And so the studies have suggested that if you've got a patient with a normal testicular volume and a normal FSH, you can probably assume over 90% of those men will have obstructive vasospasmia. If they've got smaller testes and an elevated FSH, you're more likely to be working with a guy with non-obstructive vasospasmia. The definitive way to figure this out would be, of course, to do a biopsy, which we don't do very frequently anymore, mainly because the physical exam and hormone finding is fairly predictive. So let's look at non-obstructive first. This is easily the more difficult scenario to manage. And our management has evolved over time. In the past, these men, unfortunately, were dependent on adoption. And then with the advent of insemination, you could use donor sperm. With IVF, they found that sometimes going into the testis, retrieving sperm could result in pregnancy with ICSI. And then now what we're doing is a microsurgical testicular sperm extraction, or a microtesi, which has been shown to have a much higher sperm retrieval rate. So what does that look like? Essentially what we're doing is we take the gentleman to the operating room. He gets a general anesthetic. We are opening up the testis, bivalving it. And when we bivalve the testis, as you can see here on this image to the right, what we're looking at is the tubes with the seminiferous tubules within which spermatogenesis typically occurs. In the studies have found that, you know, the testis is not homogeneous. There can be small sections of the testis that harbor sperm production. And if we can find those areas, then we can sometimes retrieve those sperm and use them for ICSI. And so the way that I do that is with an operating microscope. And so we see these tubes, they look like little noodles, right? And so for those who are fans of Japanese food, what we're looking for is the difference between the ramen noodle and the udon noodle. And so tubules that are more likely to have spermatogenesis are going to be thicker and plumper. And so these are the udon noodles that we're looking for. These are the udon noodles that we're taking out. And then after we take them out, we have an embryologist or an andrologist in the room as well, who is then processing the tissue to try to find sperm. And so here you can see he's pulling out the larger tubules that are more likely to have sperm compared to the tubules around the side that are quite small. All right. So what are our success rates with this? It does depend on the etiology of the non-obstructive vasospasmia. These are some of the common conditions that can result in non-obstructive vasospasmia, as well as the sperm retrieval rates and pregnancy rates based on some of the studies that have been carried out in big American centers. So in terms of all comers, sperm retrieval rates are about 55%. And pregnancy rates are just slightly lower than that. And the sperm can only be used with ICSI. So let's look at the other side. Let's look at the obstructive vasospermic male. This problem is much easier to manage because he should be producing sperm. And so as long as you can get upstream to the obstruction or to the blockage, then we should be able to retrieve sperm, and that sperm should be able to be used for ICSI. And so the sperm retrieval options, we can get sperm from the testis itself. This can be done percutaneously. They can be done under local anesthetic with an open procedure, or we can get sperm from the epididymis, and that can be done either in the OR or percutaneously as well. My preference has typically been to do an open testicular sperm extraction for a couple of reasons. I find that it's a more controlled environment. So if there is a little bit of bleeding, it's easy to control with cautery before you close it up. And when you're trying to get tissue, you do need a fair amount of tissue, and using needles doesn't often give you adequate samples compared to being able to make a small incision on the testis and taking a sample that way. In men who've had vasectomies, the other option is trying to reconstruct the outflow tract. So that's a vasal reconstruction. Men who've had vasectomies, as you can see here, they've just had their vas deferens divided, which prevents sperm from getting from the testis to the ejaculate. We've got two options for vasal reconstruction. The more simple one is called a vasovasostomy. And what happens here is I cut out the scar from the vas deferens. I look at the the fluid, and if there's sperm there, then I'm confident that I can reconnect the vase to the vase and under a microscope and try to reconnect that pipe and reestablish that pathway from the testis out to the ejaculate. And if we're able to do this repair, then the chances of patency, which is getting sperm back to the ejaculate, are pretty good. They can be up to 90%. That allows men to have the option of trying to conceive naturally. Now, it's a fairly fine surgery. We're using very fine tenon sutures. We do it with the help of an operating microscope, placing 10 or 12 small sutures to reconnect the pipes. And we do it on either side. If for whatever reason we cut out the old scar and we're not seeing sperm at that site, then we have to go, there's likely a blockage further back. And so we have to bring the vas deferens all the way back to the epididymis and attach it at the level of the epididymal tubule. The epididymal tubule is much smaller than the vas deferens, so this is a much more difficult operation to do. And as a result, the patency rates, or the rates of getting sperm back to the ejaculate, are much lower. They're only about 55 or 60%. And without actually going in and cutting out the scar from the old vas of vasectomy, we don't know what type of surgery we'll have to do. The one predictor is time from vasectomy. And so usually if men are getting past 10 years from their vasectomy, there's a higher chance of us having to make this more difficult connection, which is why in the community there is that concern that older vasectomies can be harder to reverse. So that kind of represents a fairly quick run through of how we approach male infertility. I think the key points are that, male factor can contribute to about 50 or 60% of cases, so the male does have to be investigated. The basic investigation is the semen analysis, the endocrine evaluation, and the history and physical. The treatment strategies optimization can include lifestyle factors, medications, and surgical interventions in conjunction with the reproductive endocrinology team. So with that, that's all I've got, and I will pass things back to Dr. Dunn.
Thank you so much, Dr. Bach. So we have 3 minutes for questions, and that doesn't mean that we will ignore them. What Dr. Bach will do is we'll answer what we can live, and then he will type the answers below your question in the chat box. So all questions will be answered. Everybody